So good morning, good afternoon, or welcome to the noon hour. I want to welcome everybody to our webinar today. This is our webinar from the NIA that's going to be focusing on the new RSV vaccines for older adults, what adults over 60 and their care providers need to know. My name is Dr. Samir Sinha. I'm a geriatrician, but I'm also professor of medicine at the University of Toronto, and I'm the director of health policy research at the NIA. And I want to welcome everybody who's joined us today for our webinar. And just I want to start by just giving a few housekeeping rules. So just for our webinar today, just want to note that all of our audience members' microphones are muted. But if you do have any questions for us, for our speakers, we have two mechanisms that you can communicate with us at the bottom. For questions for our speakers, you can please use the Q&A box at the bottom of your screen. So you can pose any questions so that when we get to the Q&A portion, that's where we'll look for your questions there. And if you have any technical issues at any point during the webinar, you can use the chat box as well. And anything that's not a question, you can put that in the chat box. And we've got our members of our team joining us for today. Just as we get started, we always like to recognize that the NIA, the National Institute on Aging, is based in Toronto, Canada, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas of the Credit, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So we're all here today to really talk about the new RSV vaccines, because you may have been hearing a little bit about this on the news, that recently one vaccine became available and others are on their way. But I think for many people, when I'm in my clinic right now, and for my colleagues as well, they might say the same thing. I've been having conversations where people say, what is this RSV and why am I only hearing about it now? So this is why we put this webinar together today, to really give people the information that helps to give folks an introduction and then understand what these new vaccines might mean for us. And my colleagues, Dr. Marla Shapiro and Dr. Zain Chagla, will join us for the second half of this webinar to have a chat with myself and then with all of you as well. So what is RSV? Well, RSV is respiratory syncytial virus, and it's an RNA virus that infects the airways in the lungs. So we consider it a respiratory virus. And it has similar paths of transmission as other common respiratory viruses, such as a lot of us are thinking about it these days, flu and COVID-19. It's largely a seasonal virus, with most cases occurring during the fall and winter. And often it causes mild illness with cold-like symptoms, but it can lead to very severe outcomes too in older adults. So just to give us a sense about the seasonality of this virus, because like influenza, RSV is a very well-established seasonal virus. So when we have this cold and flu season, you should think about it as cold, flu, and RSV season as well. And this is just a nice infographic that really shows that it starts to pick up steam in October, but it's really that November to May is a typical RSV season as well. And hence why we're trying to raise awareness about RSV, especially as we are about to enter the season itself. When we think about RSV, we know it's a highly contagious virus, and it can spread rapidly through households. And I think it's important to appreciate this, because this is a nice chart that shows that between someone getting exposed to RSV to when their symptoms can begin is almost around 4 days or so that it can incubate. And to give some perspective to that, when you think about COVID-19 or influenza, it doesn't usually take that long before you necessarily will develop symptoms. And so therefore, someone might be infected for a while before those symptoms develop, and can give an opportunity for more people to become infected. So this gives you a sense of kind of how contagious this virus can be, and that's why we often see it spread like wildfire amongst children around cold and flu season. And certainly if young children are interacting with parents and grandparents in particular, you can see why, with it being so contagious, why it can rapidly spread through households pretty quickly and have more significant outcomes as well. When we think about RSV versus kind of influenza and COVID-19, it's also helpful to appreciate that there's some distinguishing features that should raise that suspicion for RSV. So we talked about how RSV has usually a more gradual kind of onset of symptoms versus something like influenza. And while we talk about kind of things like nasal congestion, productive cough and wheezing, for example, we know that you're more likely to see fevers and muscle aches with things like influenza and COVID-19. And so often when someone has some cold and flu-like symptoms, for example, or cold-like symptoms, if they don't have a fever, they might think this is not really a serious kind of viral illness when it very much could be something like RSV. So it's that lack of a fever that is often present that can often get people thinking that they might not have something as serious as influenza or COVID-19 when it could very well be RSV. And when we think about RSV as it's a virus that often can occur and allow people to be reinfected with this virus over time. So it's not that you get an RSV infection once, when you're young, and then you'll never get it again because you build lifelong immunity. We know that people are often getting recurrent infections throughout their life. And we know that the challenge with RSV is that right now, if people get an RSV infection, often that immunity can be incomplete and it can be short-lived as well. So it means that you will get some immunity after an infection, but then it will probably wear off, and therefore that certain populations, especially those who might have multiple chronic conditions, for example, or who might be immunocompromised, be at risk of more reinfection as well. So we know that RSV as well, it's often seen as a children's issue. So you may have remembered a lot of news reports last year when we were talking about a triple-demic of RSV, influenza, and COVID-19. And often what we were hearing on the news was about how especially young children were flooding our hospitals, and our pediatric hospitals in particular were quite overwhelmed because it can lead to a significant high rate of hospitalizations amongst children under 2 whose immune systems aren't as well developed, if you will, and are often getting that first RSV infection, which can be more nastier than subsequent infections over time. So we often think about it as a children's issues because this is where we see the vast majority of hospitalizations occurring amongst our population overall. So you can see really specifically amongst people under 2 and in that 2 to 4 age range, and then beyond the ages of 5, it seems to kind of really peter out where it doesn't lead to a high risk of hospitalization until you start seeing that age group 65 and older. But the challenge is that we know that RSV hospitalizations will increase dramatically with age. And so when you see that small group that you see where that rate of hospitalizations that starts to raise with older people, this is an interesting study that actually kind of has shown us what rates of hospitalizations can be. And we can see that while all adults, it's around 15 per 100,000 individuals, we can see that especially once you get into your 70 and 80 plus year age groups, this is where you can see a significant increase, a dramatic increase in hospitalizations. But the other challenge that we have is that hospitalization rates that we have don't always show the full picture. So when people come into hospitals, we'll test them for viruses, and we often will test people for COVID-19 or influenza, because if we get the diagnosis right, if we say, this is the right virus, then we actually have very specific treatments for those viruses in particular that we administer to somebody in hospital to improve their overall outcomes. For RSV, we've never really had, and we still don't have any effective treatments for older people. And so for that reason, we don't usually, or we haven't in the past routinely tested for RSV unless we're trying to figure out, why is this person still sick? It's not COVID-19, it's not influenza. Could it be RSV? But often if it then ends up being RSV, we're providing what we call supportive care or supportive treatment. We're just giving people oxygen, fluids and support, and hoping that they're going to cover well. So often when we think about the number of RSV identified cases, that's what's indicated with these dark green bars here as well. When you look at this population 65 and older, we probably are underestimating the level and the rates of hospitalizations that are occurring amongst our older population, because there are the RSV identified cases, but about 90% of the what we assume are attributed cases are not necessarily identified as well. And so this is why we're probably underestimating the burden of RSV on an annual basis in our society, and especially amongst our older population. Now, this is also a really nice slide, because it also helps to better appreciate kind of the burden of RSV across different age groups. So what you see with the blue bar is it looks at kind of when you look at kind of from the left to right, what you see is under the age of 5, that's where we see 70% of our hospitalizations that are occurring. And so we see that this is where the majority of our hospitalizations are occurring amongst that young population, whereas for older adults, they represent about 22% of the hospitalizations. But when we actually look at the impact that RSV has on those populations being hospitalized, the good news is for that really large group of young children under 5 who tend to represent the majority of hospitalizations, the good news is for young children, very few of them will get sick enough where they will not survive. And so when we look at the share of RSV deaths, we really see that while RSV can certainly hospitalize you as a young child, the chance that it'll kill you is very low. But that's not the story for older adults, because when we look at that proportion, that 22% of older adults that represented the group that was being hospitalized, we found that about 1 in 9 of those who were hospitalized ended up dying. And so we find that while this population represents a minority of the overall attributed hospitalizations, we find that they represent almost 85% of all deaths. And this is Ontario, Canada data that we had as well. So what we do know is that, older adults do have the highest mortality rate. And so this is a slide that helps to kind of put that in perspective, that again, the good news is that while younger people are much more likely to end up in hospital with RSV, we know that the significant risk of mortality occurs amongst our older population. And that previous slide I showed you as well shows that, especially when we look at the older population, the older you get, and the more likely you have what we call comorbidities or other chronic illnesses, increases your risk of death as well. So really helpful to appreciate why this is such a burden in our older populations, and why we need to take it really seriously in this population as well. This is also helpful to kind of also appreciate what happens to older adults who are hospitalized with RSV, because they tend to experience not only a higher risk of death, but also other complications as well. So typically hospitalization will last 3 to 6 days. Unfortunately, upwards of 31% will end up in the ICU. Of those who end up and of the overall population, 3 to 17% will require life support via mechanical ventilation. And as we noted before, of those people being hospitalized, about 6 to 8% in this study represented the folks who ended up dying in hospital due to their RSV complications. So it really reminds us that if you're an older adult and you get hospitalized with RSV, this is not typically going to be an easy hospitalization course, and why we see that up to 1 in 9 people end up, unfortunately, passing away. And it's not just about being in hospital. We know that typically of those people after they're discharged from a hospitalization due to RSV, we know that in this other study they showed that 1 in 3 patients, by the time they were discharged, 6 months after that period, were still operating at a lower functional baseline, meaning they were having more trouble walking around, doing transfers, toileting themselves, so basically living independently. And unfortunately, 8% fewer patients were able to live independently 6 months out from that hospitalization. So it's not even just the risk of ending up in hospital and the potential complications there, but for those who are lucky enough to make it out of hospital, we know that up to 8% have lost their ability to live independently thereafter. So it's those knock-on effects that we think about that I know that for my older patients, they value the most. They want to stay healthy and independent, and realizing that these viruses can certainly potentially steal that away from you is really kind of the bigger thing that people want to avoid. So we also know that when we think about, it's not just about age being a greater risk factor, it's also the growing risk if a person has an underlying chronic health issue, for example. So we know that if someone has asthma, diabetes, if they're immunocompromised, if they have COPD or congestive heart failure, we know that this increases one's risk, from 1.39-fold to 2.38-fold, increases that risk of having serious versus non-serious outcomes as well. So it's not just about being an older person, 60 and older, but it's also saying that if you're an older person and you also have one of these chronic conditions, and I'd even say if you're a younger person than 60 and have one of these chronic conditions, this is why we have such a focus on getting these people vaccinated, not just for everything that's related to respiratory issues like influenza, against pneumococcal disease, but also COVID-19, and why this is also an important factor when we think about complications related to RSV as well. We also know that there's also this kind of vicious cycle that can occur with time. So the idea that if you have underlying comorbidities, as it's indicated on the right side of your screen here, if you have some of these chronic conditions, for example, this makes you more susceptible to certain infectious diseases, and then makes you at greater risk, for some of those negative consequences if you get those viruses as well, for example. So that's why that's why we think about the importance of not only just thinking about increasing age, but we know that as we get older, we're more likely to be living with additional comorbidities that can weaken our immune systems and weaken our ability to fight off infections. So that's why we become more vulnerable to certain infectious diseases, and that's why we can be more vulnerable to the consequences, and it becomes, if you will, a vicious cycle. So we know that older adults are greater risk, not just because of age, but due to the things that are associated with aging. So the three things that really do happen are, we talked about this last point already, that there's an increased risk of living with multiple chronic health issues, or at least one or more chronic conditions, for example, as we age. But as we also age, we know that our immune systems tend to decline in their overall strength and their ability to fight off infections. That's why vaccinations are so important for us as we age, but also really important to young children who are just still developing their immune systems as well. So that's why we really focus on immunization at the extremes of age, but why it's particularly important for older adults, because we see a natural decline in our immunity. We also know that that from a respiratory standpoint, our lung tissue that we have, it experiences mileage over time, and that aging lung tissue isn't as robust and as able to fend off the consequences of infections as well. And so whenever we have infections, this can damage our lung tissue, and especially if our tissue is older, for example, it may not be as resilient as well. And so this is why it's kind of this vicious, kind of triad of things that can add up, that can make us at greater risk to RSV and other respiratory viruses as well. We also know that the challenge of RSV can happen because sometimes we misdiagnose, RSV. I mentioned before that we might say, oh, this might just be the common cold, but not appreciating that this could be RSV. And one of the challenges that we have is that we might be saying, oh, well, we're more likely to take it seriously if there's a fever present, but people with RSV don't necessarily always have a fever present. So we might actually chalk up a potential RSV case and misattribute it or misdiagnose it because we don't recognize it as RSV, and we don't think it's as serious as maybe other respiratory conditions, but it's a serious one. And there's an under-recognized recognition that this leads to, because then we might be less compelled to actually do a swab, for example, to confirm, is this RSV, just like we would be more inclined to look for COVID-19 or influenza. So that's why we tend to have an under recognition of this, because we tend to test less for this as well. There's often a perception that adult RSV is mild and manageable, because we often think about young children who get hospitalized, but not appreciating that older people who get RSV are more likely to have those severe and negative consequences compared to younger children. And then there's also this apathy that sometimes happens towards a diagnosis. We say, well, why bother testing for it if we don't have an effective treatment? So that's why people may not be as keen to identify it once someone gets sick. But that's why talking about vaccination is important, because now we finally have something available that can prevent RSV in the first place, or significantly reduce its consequences should we get infected. So we know that older adults also with RSV infections experience a similar risk of mortality compared to those with influenza infections, because some people say, okay, so there's this RSV, it's a virus, but I get my flu shot every year. I'm going to get my latest dose of COVID-19, but RSV, is that something that I need to take seriously? Like, how does it compare it against the flu? And what we want to emphasize here is that when you look at the overall data, we know that those who experience influenza infections, they have a similar risk when they're infected with RSV. And this was a study that was done that actually looks at RSV complications in older hospitalized adults versus influenza. And what you can see here in this study was that when they looked at people infected with influenza or RSV, so this older population, what you can see is there is, a pretty equal, if not sometimes worse, risk of things like cardiac complications, hospital readmissions within 3 months, or even deaths during hospitalizations. And so often we can see that we should, if you're worried about influenza, then RSV is something that you should be equally concerned about, because both of these can have significant consequences for older people. The good news is, if I made some of you a bit worried or scared about RSV, is that the good news is now that while we don't have effective treatments to treat someone once they have an RSV infection, there actually finally is available a vaccine that helps prevent RSV infections in older adults. This is the good news, and this is why we're all here today. People love science and understanding. And I think when people start saying, well, how does this vaccine work? I think people have now become more expert around things like the COVID-19 vaccine, and appreciating that it was built around, the spike protein in a similar way, keeping this at a very high level. Over time, there's been decades of research that have been trying to figure out how to make an effective vaccine against RSV. And really, like the spike protein, there's a different protein called the fusion protein of an RSV, or a pre-fusion protein. And this is actually what's been identified as the right target to develop effective vaccines. So that's similar to kind of COVID-19 in that way. We figured out kind of what is the right protein to target to develop an effective vaccine as well. And in doing that, there are now currently 3 unique RSV vaccines that are being developed. So there's 3 different manufacturers out there. People are familiar with Moderna and Pfizer, and GSK. These are 3 global makers of vaccines. And they've all taken a slightly different approach, but it all is targeting that same pre-fusion F protein. And so the Moderna vaccine is kind of doing a similar mechanism as has been done for their COVID-19 vaccine, which is using an mRNA platform, whereas GSK and Pfizer have done used a protein subunit-based vaccine, where again they really focus a vaccine made around the specific proteins themselves, and use a mechanism to help get that and to build that vaccine to help give us immunity as well. And so there, as I mentioned, there's 3 different vaccines that are currently in development right now. And this just reminds us kind of how vaccines get approved and become available in Canada. Right now, there is currently one vaccine that has completed its phase 3 development, has completed its regulatory submission to Health Canada, and now has gained market approval, and that's the Arexvy vaccine by GSK. There's a vaccine that was developed by Pfizer called Abrysvo, and that one has been submitted in April 2023 for its review by Health Canada. And so they anticipate that at some point over the next year, there should be market approval for that. And Moderna hasn't yet submitted its regulatory submission to Health Canada. So it reminds us that there is a process, and not only does it take time to go develop a vaccine, put it through all these trials, and then actually submit that data to regulators around the world. But this is kind of what the process is right now, and in Canada at the moment. And right now, the question is, how effective are these vaccines? And so when we looked at the vaccine efficacy rates reported amongst these 3 different kind of vaccines that are being created, so far in terms of their outcomes of their studies right now, we know these are pretty effective vaccines. What we looked at here is just presenting, we're not going to talk about each of the individual vaccines. We'd be here all day to look through all the studies. But really what they've all looked at are kind of similar outcomes. They've all measured these things a little bit differently. So you can't do a hardline comparison, but what they've looked at is the types of disease that these vaccines can be related to. So when we look at this idea of lower respiratory tract disease versus upper respiratory tract disease, we know that these vaccines are at least 66% effective against lower respiratory tract disease. And that's the more serious disease that will land people more in hospital and have quite severe outcomes as well. And amongst people who have high-risk conditions, again, we look at this being at least 62% effective. And against severe RSV outcomes that are the ones that we look at that can include hospitalization, they're particularly effective, at least 82% effective against severe lower respiratory tract disease. And that's the key thing, is most people are interested in vaccines that are going to help them stay out of hospital and keep them from being in the ICU or dying and losing their independence. And so that's where we want to see a good level of efficacy around these vaccines as well. So we know that right now, while NACI, our National Advisory Committee on Immunization, has not come out with its recommendations, they're planning to come out with recommendations around these vaccines for Canada next year. In the United States, the Centers for Disease Control, they have their own committee called the ACIP committee, and their recommendation is that adults age 60 and older may receive a single dose of the RSV vaccine using shared clinical decision making. So again, they've given their kind of their statement saying that they think this is something that older people, 60 and older, should consider using shared clinical decision making. And the key question people say is, okay, so I'm thinking about getting this vaccine. Can I get it with other vaccines? And the key piece is that this has been studied by these manufacturers related to giving it with other influenza vaccines. And ACIP, that group from the US Centers for Disease Control, has actually advised that the co-administration of the RSV vaccine with other adult vaccines is acceptable with the consideration of various factors. So the good news is that we have looked about co-administering it with things like the flu, and even ACIP recommends that you could probably give this safely with other vaccines as well. So right now, in terms of when we look at this current vaccine being available, so the only one available currently in Canada is Arexvy, and it can cost people up to $300. The good news is some private drug plans may cover the cost of the RSV vaccines, and currently the only province or territory that's providing any government coverage of this is Ontario, that's currently covering the vaccine for older adults living in long-term care and some retirement homes as well. But the good news, as I mentioned, is that for those who are lucky enough to have access to a private drug plan, many of these are also covering the cost of this vaccine as well. And right now, we know that when we start looking at our rates of immunization or vaccination rates amongst Canadians 65 and older, right now, while we're recommending that everyone get an annual influenza vaccine, that older Canadians get a pneumococcal vaccine and a shingles vaccine, we know that PHAC right now has set a target of 80%. We've never reached that for influenza. We certainly are far behind on the pneumococcal and the shingles vaccination. And so we have a lot of work to do to try and get more people aware about the importance of vaccination for our older Canadians and making sure that we can reduce barriers like cost, convenience, and access. The NIH just put out a report. So if you want to learn a lot more about RSV and everything we've talked about in this webinar so far, you can find that in our latest report that's available. And my colleagues, I'm sure, are going to put a link to this report in the chat as well. But the key is that we end our report with 9 key recommendations, and really recommendations for Canada to move forward around RSV. So not reminding us that we should always be promoting general preventative practices, hand hygiene really important, and making sure that we're doing things that can help prevent the spread of respiratory infections. But we need to do a better job at improving our surveillance of RSV infections and better testing for it. We want to make sure that we continue to work on the development of RSV vaccines. These are new, these are out there, and there's more work that can be done to improve them and understand them better. And we want to make sure that people, have access to these vaccines. And we've recommended that it be made free of cost to populations for which this vaccine is cost effective. And for older populations, this has been found to be quite effective, quite cost effective in general. We promote following kind of the guidance that our National Advisory Committee on Immunization will give. They're planning to give this in about a year, but again, we can look to our US colleagues to see what they're recommending and apply that right now. And we need to do a better job of making sure we inform the public, but we also make sure that our pharmacists, our primary care, and other healthcare providers are well aware of these vaccines and do a better job of making sure that we do a good job of monitoring our vaccination rates and harmonizing vaccine administration across Canada within our provinces and territories as well. So again, if you want to read more about the report, you can read more about our recommendations and understand a lot more about this. But now I want to bring in my colleagues here, Dr. Marla Shapiro and Dr. Zain Chagla, who kindly joined us today for this webinar. I'm going to quickly introduce them because they are quite impressive individuals who have a lot of experience in this space. So I'm going to first introduce Zain. Zain is, Dr. Chagla is an infectious disease consultant, and he's associate professor of medicine at McMaster University. He is also an infectious disease consultant, as I mentioned. He's the medical director of infection control and the head of infectious disease service and the interim senior medical director of clinical operations at St. Joseph's Healthcare in Hamilton. And he's a member of the Institute for Infectious Disease Research at McMaster, and he's a council member of the AMMI Canada, or the Association of Medical Microbiology and Infectious Diseases group. Dr. Chagla holds a BSc and a medical degree from Queen's University, and he did his internal medicine residency from Western University and his infectious disease fellowship at McMaster, as well as a Master's of Science in Infectious Diseases and a diploma in tropical medicine from the London School of Hygiene and Tropical Medicine. So well equipped to join us today and bring his perspective as an infectious disease consultant. We also have Dr. Marla Shapiro. Dr. Shapiro completed her medical school at McGill University and trained at the University of Toronto for her Master's of Health Science. She concluded her specialty training in community medicine, receiving her fellowship in preventative medicine and public health from the Royal College of Physicians and Surgeons of Canada. She also holds a fellowship in family medicine and is currently a professor in the Department of Family and Community Medicine at the University of Toronto. You may have seen Dr. Shapiro on CTV News Channel. She is their medical expert expert, and she's also the author of the best-selling book, Life in the Balance, My Journey with Breast Cancer. In 2015, Dr. Shapiro was named as a member of the Order of Canada for her contributions as a family physician and a trusted source of health information. And she's one of and the Order of Canada, for those of you who don't know, is one of our country's high civilian honors, recognizing outstanding achievement, dedication, and community and service to the nation. So Marla and Zain, if I can address you by your first names, thank you for joining me today and being with us for this webinar. So I've just given a ton of information, and I'm sure people are swimming in this information. And so I'm going to come to you, Zain, first, and ask you, one of the questions people, say, is there like, RSV? Why are you raising this? I haven't heard about it before. I started hearing about it last year when it was all over the news. But is this a new virus? And this vaccine, why do we just have a vaccine for this now if this is a virus that's been around for a while? I mean, any thoughts around that? Because I'm sure you get that question quite a bit from some of your patients as well. Oh, and Zain, we have you on mute, right?
Of course I'm on mute. So thanks for that, Samir. And absolutely, it is a big question I get asked when we talk about this. People recognize RSV. They may have recognized it before as a childhood disease, especially if they've had children or grandchildren that have been infected. But really, as an adult disease, we really don't talk about it much. I think you described some pretty compelling data, though, in adults that really is a problem. And so the big question is, why has the medical community ignored it for this long? The answer is we haven't. It's just we haven't had anything to offer. So, I think we all recognize RSV as a terrible infection in adults. And there's been a lot of work on RSV vaccinations that's been ongoing actually for decades. In the 60s and 70s, there was a number of different vaccine targets, but this was in the early days of vaccine development. And unfortunately, many of those trials did not work out and patients did not get the benefits from the vaccine. And a lot of this had to be put on, the drawing board again to figure out exactly why these vaccines weren't working and what the mechanism of it, people developing good immunity and a vaccine target for RSV. The last 20 years has really had a ton of research around this. And so you describe this pre-fusion protein on the surface of the virus that is the target for the vaccine. It took a long time to identify that. And it took an even longer time for us to kind of keep that protein the way it is so that it triggers our immune response properly. Once that was discovered, and that's really work that's been done in the last few years, that really opened the door for these clinical trials to start. And that's why all three companies are coming, to the market in the same kind of time frame with RSV vaccines, because this technology is really, really new and novel. It's based on decades of research, but really now puts a solution to a problem that we all experience. So, RSV is an issue. It's a costly issue. It's an issue that makes people sick. It's an issue that takes people's independence away. It's an issue that unfortunately kills some people in hospital and in the community. But I think we can be fortunate that decades of research have actually culminated into us having solutions to this problem rather than being apathetic and shrugging our shoulders and saying we don't have much to offer here.
No, thank you, Zain. And I guess the question is, so I presented some of the data, and again, you're very familiar with, the three different kind of vaccines that are developed, and there's these different endpoints. And I guess one of our folks has asked, is one vaccine maker more superior or robust versus another, and how good are these vaccines overall? Like compared to, we sometimes hear that the influenza vaccine, is it a good match? Is it that effective? Or sometimes there's different levels of effectiveness. How do we look at these different vaccines and these results? Like, how good is this vaccine?
No, absolutely. And so, number one, it's very hard to develop vaccines for respiratory viruses. And it's because, rather than the vaccines that target other infections in our blood, where we have really good levels of antibodies, respiratory tract has different immune responses, and it's hard to keep your immune response really high in certain places. And we know that with the influenza vaccine, because of the way the virus evolves, we have to, and the way our immune system evolves with it, we have to do yearly vaccines to match the strain. Now, when we look at these RSV trials, we see 70, 80, 90% protection. Some people don't know exactly how to place that, but good flu season, 60% protection is considered a great success, that we match the flu vaccine appropriately. So when we're talking 70+%, that is really, really impressive, particularly for a respiratory vaccine, and with the challenges that are in vaccine development. And I think to add to this, we actually do have a little bit of data for what the second year looks like after getting a vaccine. So the GSK vaccine incorporated is actually ongoing, that trial. So it's looking at year 2 and year 3. And they looked at folks, they gave some of them a booster dose. They left some of them alone and just gave them that first dose. And they compared it to people that got no doses. And we're still seeing close to 80% protection in year 2. The good news is we're actually also seeing that 2 doses versus 1 dose of vaccine actually are entirely the same. So a single dose of a vaccine could likely protect people for 2 seasons. That's really, really impressive in the context of a respiratory vaccine. So, this is really good news. This is, again, I can't emphasize as much. This has been a scientific story that's incredibly successful, that's really helping patients right now. And, again, 70 to 80% success rates in preventing severe disease or lower respiratory tract disease is really, very good for vaccines in this domain.
Oh, that's right. And I think you helped answer Grace's question, because she was like, is this RSV, is it an annual vaccine? So I'm going to take that question over to Marla, because, right now in your busy family practice, you're talking to your patients about vaccines all the time. And right now, I think, in terms of, as people are having those conversations with you about, RSV and other respiratory vaccines, how are you, kind of raising this opportunity with your patients about having that conversation about this in relationship to their other vaccines, especially when people ask about, can this be co-administered, for example, and how do I approach that?
So I think this is a very exciting time in family medicine and prevention in general, because we know that many of these pathogens are responsible for not only death, but disability. And one of the most aha moments I had looking at the data for RSV is that 6 months out from this illness, you can still be unwell and not return to your pre-RSV experience in terms of quality of life, independence, activities of daily living. So this is really significant, not just in terms of mortality, but independent living. And it really is quite a nasty virus that up until now, we haven't had good surveillance, we haven't had good treatment, but now we have good prevention. So the numbers here are terrific. And I'm telling my patients that, yes, I know that there are a lot of vaccines, and aren't we lucky that we have science and technology to give us the opportunities to make a real difference in the quality of our life. So right now, I'm giving high-dose flu shots, either Fluzone or I'm giving Fluad. At the same time, I'm co-administering an RSV vaccine. And we're also talking about making sure that you stop counting the number of COVID shots you've had. It really is a question of being up to date. The exciting thing about RSV that we haven't really talked about is that there's 2 different types of RSV, RSV-A and RSV-B, and the target for this vaccine is very similar in both those RSV-A and RSV-B. So it works for all the circulating RSV. We also know that natural infection with RSV doesn't give you any long-term immunity. So you can get infected year over year over year. So the fact that we have stability of immunization protection ongoing, as Zain has told us, for up to 2 years now, and who knows, it might be longer because the study is ongoing, is very exciting. And the other thing that's different about RSV than the flu is that it does not change from year to year. RSV is fairly stable. So it's not like you need an updated RSV vaccine in 2023, and then in 2024, we're going to have to do this technology all over again. It looks like the same vaccine will continue to be effective the same way that we have pneumonia vaccines that are effective. So, I'm basically saying that the best prevention you have is the strategy of immunization. We've learned that mitigation strategies, washing your hands, masking, is all well worth thinking about. Staying home when you're unwell, sneezing into your sleep. We're not going to abandon those strategies, but these vaccines are really exciting. And while we do have a lot of fatigue about vaccines, I'm giving 2, 3, and sometimes 4 vaccines in the arms of patients when I'm seeing them now in the fall season. So I can tell you tomorrow we're running a flu and RSV clinic just so that we can get lots of people in. And it's staggering when we look at the response of everybody who wants to have these vaccines. And I think it's a very exciting time in terms of offering these vaccines. So you can co-administer them. Yes, you may feel a little sort of fluish or unwell for a day or so, the strategy of this vaccine is that it has an adjuvant the way the shingles vaccine did. That's why it's lasting longer. It's got something in there to boost your immunity. It may make your arm a little sore, but for the most part, most of my patients are rolling up their sleeves and getting their vaccines.
No, that's excellent. And I think, and one thing you really focused on as well, Andy had a question about thinking about it's, some of the data just talks about, mortality rates, especially in older adults. And Andy really, I think you answered it really nicely. It's about that quality of life, and kind of that piece that really hit you was that, for so many folks, it's not just about, protecting people, from mortality. It's that, this might not kill you, but for example, for so many people, it can really harm their overall quality of life, and why we think of the importance of that prevention, that mitigation strategy in the first place from any of these outcomes that could really impact someone's quality of life. So a really good point that you've raised about how this can be so helpful from that perspective. I guess one thing is, you also raised the fact, Marla, that the importance of appreciating that these vaccines can be co-administered with others, because I think probably one of the questions people have for you is, okay, so there's all these vaccines I have to get caught up on, which one should I get, or, how do I prioritize? And I think, as you've clearly said, is, you can get this with you can get this with your other vaccines as well. I just tell my patients, do not plan to do it the day before your granddaughter's wedding. Right? Yeah.
Absolutely. Absolutely. And I have some patients who say, I don't mind coming back. I don't like the idea of having two vaccines together. And that really is their prerogative. If they prefer not to have the two vaccines together, that's entirely reasonable. But I do say with some of these vaccines, shingles would be an example, and the one that we're looking at in terms of RSV, you may have a down day the next day. That's not unusual. So, right, don't do this before something that's really important in the next 24 hours. Give yourself the opportunity to have a down day if you need it.
Absolutely. The other question I wanted to ask you, Marla, is you're probably getting this question too, because whenever I'm counseling my patients, and Zain, you may have had this as well, is that people are like, so this is not covered. So if it's not covered, it's probably not important. That's
Ooh,
what that that's
no.
so that's we there's that some of that thinking that we hear, but then the other part is again, so we're advocating that this is a vaccine that we do cover, and especially in older populations where it's shown to be quite cost effective. So that's what we're working on at the NIA piece. But for when I tell my patients, in my clinic yesterday, I said, this could cost you up to $300. And I remind everybody, if you do have a private drug plan, please check that out, because there may not be much of a cost, but there is a sticker shock that a lot of people are dealing with right now. And how do you counsel your patients on that?
Right. So I tell my patients it would be great, it would be great if all of this was covered. We have the science, we have the evidence, we have the data. The fact that it's not covered doesn't mean it's unimportant. It talks about limited resources within the healthcare system, which is really difficult. But when I talk to my patients, I talk to them about the fact that if you look at something that's covered and a patient says that I want a flu shot, I'll say to them, oh, okay, so you're saying it's okay to get the flu. And they look at me and they go, like, what do you mean? I said, well, you're not using a strategy that we have, even when it's funded. So it means you're okay to get the flu. And there's a lot of mortality associated with flu. There's a lot of morbidity associated with flu. So I think that that's what you need to look at, that when you're saying no to a vaccine, you're saying, I'm okay to take my chances with the disease. The other thing that I talk to my patients about is that this is expensive. Absolutely. It's a finite one-time currency so far. But when you look at the currency of chronic disease and the outcome of disease, when you've had the ability to prevent it, and you look at the fact that 8 months out, you're still short of breath. 8 months out, you're not returning back to your independent living. You can't do your own grocery shopping. You're feeling unwell. That type of currency is currency that we can not do anything about when it happens. So I think about the currency of what it is to get the disease and the ongoing chronic disability associated with the disease. And yes, absolutely, I'm not putting my hand in your pocket. I can tell you my coverage actually did not cover it. I was surprised, but my health plan didn't have any coverage whatsoever. But I still chose to get this because I know what the exposure is like, and I've seen RSV in my practice. And it really, the prevention for me, that type of currency, I hate to say it's priceless, like one of the credit card ads that we have, but in a sense, it is priceless. And I know for both you, Samir, and you, Zain, you see these folks in the ICU. And up until now, it's not been would have, could have, should have, because we didn't have a vaccine, but now it is a would have, could have, should have.
Absolutely. So we have some, Zain, I'm going to ask you this question here. So we've got lots of great questions that have come in, and folks are asking. So I'm going to combine a few of them together. And folks are just asking, why aren't we testing for this, and why isn't this routinely being tested for? And because someone said, I'm unclear how RSV is diagnosed when it has a lot of the same symptoms as COVID-19 or flu, and why it isn't being tested for as often. And we talked a little bit about that in that, but from your perspectives, at your hospital and day to day, can you give a little bit more insight on that?
Yeah, absolutely. And I think pre-pandemic around this in the context, we used, so when in the community, for example, if people don't end up hospitalized pre-pandemic, look, we would say they had some sort of respiratory illness. We know PCR tests take a lot of technical capacity, which is our way of diagnosing these infections. And so if you're sitting with your primary care provider, you have symptoms, you want to know what virus it is, they could do a test. It might take, a few days before you get a result. And for us as clinicians, it didn't really affect that. Most of the advice was still stay home, get better, etc. There are some therapeutics for influenza that may be used, but for the most part, we didn't really have anything to offer for the other myriad of respiratory viruses. And so, this has really led to us not knowing how much RSV is in the community. There are some studies and we have some surveillance networks that look a little bit more deeply into individuals, but we estimate because of the fact that we don't diagnose in real time. Even in the hospital prior to the pandemic, and I've worked at multiple healthcare systems, not everyone got one of those PCR tests, even when they were admitted for respiratory virus infection. You go on history and symptoms, you'd rule out influenza because that had a treatment. But in the context, it was up to the clinician to decide whether or not it was worth it or not. Now since COVID, obviously, and a lot of this technology and PCR testing has become much more universal, the hospitals are testing a little bit more, especially recognizing that all of these co-circulate together. But yeah, it was a technical issue, right? These tests were available, but they weren't helpful for us to really get an individual clinical decision for a patient. They were only really helpful for surveillance. Now, and came with cost, time, turnaround. Now, again, in hospital, we're probably diagnosing a little bit more, but even at that level, it weren't technically that helpful outside of ruling out influenza, where we had things to offer people.
No, thank you. And Marla, one question that's coming up as well is that people are asking, is the vaccine, reminding folks that this is a vaccine, the RSV vaccine is one they can give up to 2 seasons of protection, but folks are asking about other populations. So someone was saying, is the RSV vaccine available for all ages, 6 months and older? And, is it available for other populations right now? So can you speak a little bit about who's available? And if people want to get it, Barbara's asked, in Ontario, will pharmacies have the RSV vaccines as well as physicians in public health?
So the vaccine right now, you have to order it. So your physician can order it in for you if you would like, and you can get it, remunerate there. Most of my patients are getting a prescription and picking it up at the pharmacies. Some pharmacists will administer the vaccine under a physician's directive. Some will not. So my patients are bringing them back to me for me to administer. It doesn't really matter to me whether I administer it to them or whether a pharmacist does, as long as I know and I could put it in their records, because I'm very keen about all our records being up to date and knowing what vaccines were given where and when. This vaccine has been studied in an age population 60 and over, so that is the on-label indication. It is not for a pediatric population. There are other vaccines and other monoclonal antibodies that are being developed for the pediatric population. So that's a different vaccine formulation that is yet to come to Canada. We don't have that at the present time. What they have in the United States, and we will have shortly in Canada, is the Pfizer vaccine will be given for pregnant women who will be having to protect their unborn babes who are expected to have their baby during the RSV season. So the same way that we give pertussis vaccines in the last trimester of pregnancy, we'll be looking at, once we get approval for this, we don't have approval for this vaccine yet in Canada. They do in the United States. It is on its way coming. That will be another group that will be targeted, pregnant women, for this particular vaccine that's been studied in pregnant women, not the vaccine that we're talking about today, RSV, which has not been studied in pregnant women. So, the question is if you're in your mid-50s and you have terrible chronic obstructive lung disease that puts you at high risk for terrible outcome, have the conversation with your healthcare provider as to whether or not you want to do this on a so-called off-label. And there are always times when we might use something because we feel the benefit is greater than the risk. But right now, for this particular vaccine that we're reviewing today, the indication is for anybody over the age of 60.
Perfect. And Zain, another question that some folks have coming in is they're saying they're hearing some different kind of advice. So one person said, one site said to avoid getting your COVID-19 and your flu shots by 14 days, either direction of the RSV shot. They said, I rather get them all at once, an ASAP thoughts, right? And so I think, Marla, you talked about, again, the advice there. And they said, and Zain, here's like a question you can ask. I know both of you can easily answer this, but they said, if someone's sick now or was recently ill, can they still get an RSV vaccine? If not, what's the wait period? Assuming we never know which of the virus types was the culprit. So, Zain, what do you say about this? Because again, I think we were mentioning even before this that there's some conflicting information out there, which I think is not helpful.
Absolutely. So, the one piece is some agencies are putting out some caution advice, and it's really the issue is that this is a newer vaccine, and a couple of agencies in Canada have just kind of said, look, it's a newer vaccine. Let's just see, don't administer with other vaccines. Not that they would conflict. And we actually have data for RSV and flu vaccines. There were clinical trials that actually showed success. But really in the context of if a side effect happens, that you could actually tell which one it came from, basically. The same thing actually happened right at the beginning of the COVID vaccine campaign. Yeah. And, many clinicians kind of said, well, this is silly because we should probably be vaccinated against both, recognizing we don't want to miss people. And, the end of the story was now that it's recommended to give COVID vaccines and flu vaccines together. So, again, this is an abundance of caution. We still want to have those individual patient discussions. And for someone who wants to get all of them done at a single time, I don't think there's a big deal about that, recognizing that most of those folks that want to get all of them done probably have seen a COVID vaccine and influenza vaccine in the past anyways. And, we have if they've had a side effect profile, we should know about it. And again, it may save that person from coming back or losing that person to the community where, we lose the opportunity to vaccinate. So, I think it's an individual discussion. It's for patients. As Marla said, there's some patients that want to space them out. Great. If there's some patients that really want to get them all done at once, great. And the recommendations to space things are really just based on an abundance of caution, which likely in a few weeks will be discontinued once we realize we know the side effect profile pretty well and we can understand what co-administration looks like.
This is perfect. I want to say thank you very much. Time always goes by really quickly. We've answered 25 questions so far, and one of the questions folks have is, is the recording and are these slides going to be made available? Absolutely. We will make this available to you. And I think part of this is some folks have asked some very specific kind of medical questions. I think the key is, those are questions that are best handled by a conversation with your primary care provider. You can certainly speak to your pharmacist or anybody else who's providing healthcare to help answer some of the questions you have around this vaccine and when you might want to administer it, and who's it right for. But we want to start the conversation, and certainly people will have access to this information after the webinar if they want to watch it again, or if they want to read the report and look over the slides that we presented. But I want to say, first of all, thank you so much to Dr. Chagla and Dr. Shapiro. The time always goes by really quickly on these things, but I think we were able to help get some clear clear, important answers to folks so that they can be better equipped to approach this upcoming respiratory season with greater confidence, thanks to your support and input as well. So I want to thank them as well, and thank everyone for attending. And we're just going to put up on here just a note of thank you to folks as well. And also to remind folks that we do have a general webinar we're going to be hosting on November 13th. That will involve our colleagues, Dr. Allison McGeer, an infectious disease specialist, and Dr. Vivian Brown, another family physician, where we're going to be talking about vaccinations in general. So it's a chance for folks to absorb some of what we talked today specifically about RSV, and we're going to talk about vaccinations in general, just so that people can, again, have more up-to-date information about this and other vaccines as well. So thank you very much, and we'll be sending out information as well in the coming week or so people know how to sign up for that webinar as well. So thank you for that last question, and again, thank you to Marla and Zain for joining me today, and have a good rest of everyone's day. Thank you.